All right, so good afternoon, everybody. Welcome back from the Labor Day holiday. This afternoon, we have Dr. Mohammad El-Ghanem, who's going to be presenting this on the evolution of acute stroke. Dr. El-Ghanem, he is currently the Director of Neuroendovascular Surgery and Interventional Neurology at HCA Houston Healthcare Northwest Medical Center. He's also the Medical Director of the Joint Commission Comprehensive Stroke Center at HCA Houston Healthcare. He did his medical school training at Jordan University of Science and Technology, and then did a residency in neurology at Rutgers University, and then followed by a fellowship in vascular neurology at University of Penn State University. I will forgive that. I'm a Big Ten guy, Michigan. So, and then he also completed another fellowship in endovascular surgery at Rutgers University, also in the Big Ten now. And he's currently an assistant professor here at the Tilman Fertitta Family College of Medicine, and is also a Cougar. He's in pursuit of a master's degree in healthcare administration and a master's in business. So without further delay, I'd like to turn it over to Dr. El-Ghanem. Thank you so much for joining us in person.
Thank you very much for having me, and thanks for this nice introduction. Thanks for having me here. My passion in life, other than treating patients, is also education and spreading the information that I have, which is limited to the generation to come. This meant to be interactive. I don't know how the people on Zoom will interrupt me to ask questions, but if I go fast or I go on a topic that you think you need me to clarify, please let me know. I like to be interrupted. You do not really disturb me at all, so please. So the main purpose of this, in my opinion, is to increase awareness, starting from us as a faculty and people in the medical field, and also probably spreading that to the community. And I will show you why this is very important to start from here, even go back to elementary school and go talk about strokes, because it's very important, because it is a disease that we can treat, and it is a disease that if you come fast, the results are way different than if you come late. I have nothing to disclose, and this is the objective of the lecture today. So to introduce the topic, I remember when I started my first job at University of Arizona in 2017, 2018, I came in, I was the first neurointerventional neurologist hired in the whole town of Tucson. And every time I walk in the hallway in the hospital, I'm like, you're what? Are you a neurologist? Are you a radiologist? Are you a neurosurgeon? So I like to start by telling people how I ended up doing this subspecialized field of medicine. So neuroendovascular subspecialty can come from 3 major residency programs, either from neurosurgery, radiology, or neurology. I did the last one, the neurology. So if you do it from neurosurgery, you have to do 7 years of neurosurgery residency. Then you add 1 year of training of neuroendovascular. If you do it from radiology, you have to do 5 years of radiology, 1 of neuroradiology and 2 of neurointervention, total of 8 years. I took the 7 years from neurology. So you do 4 years neurology, 1 year of stroke fellowship, and then 2 years of neuroendovascular. The 8 years from neurology, if you do neurocritical care, which is you add 1 year for your training. So it's a long journey, but it's something that's worth it, in my opinion. And I encourage people to look into it. It's a new field. So when we talk about stroke in general, it's not a stroke, and it's not a stroke. A stroke is a brain damage that happens from a vascular phenomenon. If you look globally, 1 in 4 people over the age of 25 will have a stroke in their family, in their lifetime. And each year in the United States, there's 800,000 people experiencing a stroke or a recurrent stroke. If you look at your watch and you just fast forward 40 seconds, every 40 seconds, someone will have that stroke in the US. And every 4 minutes, someone will die from a stroke in the US. So it is a disease that's not uncommon. The problem that comes from stroke, I think it's not only the incidence prevalence, it's the disability consequences that comes with it. I like to put things into perspective. This is when I talk to students, even my colleagues. If you see someone walking in the street on a wheelchair, let's say, or a walker, and you want to guess what is the most common cause of this person being disabled, the best guess is a stroke. So it is the #1 leading cause of disability in the US. Then it comes afterwards, car accidents, heart disease, and you name it. But #1 cause of disability is a stroke. So that comes when you are a functioning person. And again, we talked about the stroke can hit anyone above the age of 25. I've treated people even below the age of 25. Highly functioning person, boom, stroke, then you're not functioning. So it has a lot of consequences at the community, state you live in, then the country at large. The second fact that I always ask and stress to tell people is stroke is not a one lifetime event. If you have a stroke, so probably you have a risk factors to have strokes. And if you do not engage yourself in a healthy lifestyle, your chances to have another stroke is higher. So if you have a stroke one time, you get treated, you're not disabled, went back to work 100%. If you do not take care of your lifestyle and medical problems, you're going to have another one. I'm going to skip through this. So if we want to classify the strokes, there's two major categories of stroke. There's ischemic stroke, which is the one on the this side. And hemorrhagic stroke is the one with the bleeding. So it's either the blood vessel gets blocked from within, lack of blood supply, you lose oxygenation to the brain and the brain dies, or you have a bleeding from high blood pressure, bouncing blood pressure that's not controlled, and then you have a bleeding. Luckily, the ischemic stroke is more incident or more prevalent than the hemorrhagic stroke, because hemorrhagic stroke, when it happens, it can kill patients within 24 hours. It's just a scheme to show you the difference. This is how the hemorrhagic strokes looks like. This is a ruptured aneurysm causing bleeding and other types. The key, in my opinion, when it comes to stroke, because a stroke is treatment is time dependent, is how to pinpoint that this person has stroke. I can ask anyone in the street, if you have someone walking the street stopping on a bus station and they do this, what's this? It says heart attack. But stroke sometimes is very tricky to know. And I can tell you in my fellowship, one of the things that I like to do is to do community outreach. So we went to a baseball game and we had a booth in Penn State, one of the stadium at the beginning of where people comes into the stadium. And my whole question was, do you know what stroke is? And I can tell you probably 20–30% of the people know what stroke is. They start to talk about stroke, which is, I said, stroke, swimming stroke or stroke baseball. So lacking community awareness of a stroke is #1 problem that we face in such disease. But generally speaking, stroke is a loss of brain function. And we know the function of the brain is usually right is left, left is right. So the left brain supplies the right or controls the right side of the body and vice versa. So it's usually unilateral. Unilateral is one side, weakness, one side, numbness, visual disturbance, vertigo. We can name it, but and you can go over medical terms, aphasia, neglect, confusion. I don't want to go into these. Each one of those needs 15 minutes of explanation, showing you brain anatomy, which nobody likes. Probably people will go to sleep if I show brain. But we're now the emoji era. So if you want to text someone that I have a stroke, I like this emoji. This is the stroke emoji, because the acronym that we use to educate people about stroke is BFAST. It helps us spread the information about stroke symptoms in a very simple words, and also highlighting that you have to be fast to get treated and to reverse your stroke. B for any balance issues. And all of these symptoms should happen acute, meaning you are normal, second, then you're abnormal. It is not something that happens over days and weeks, like numbness in my hand went up to my shoulder, then my shoulder is more weak, then my right leg. Stroke does not travel over. It's like It's a switch. Blood supply, no blood supply. There's a blood supply, the brain is functioning. Cut the blood supply, you have no function. So B for balance, E for any eye problems. Either half of the vision is gone or the whole vision is gone. F for facial droop, facial asymmetry, one of your faces not moving. A for arm and leg weakness. And S for speech, any speech problem. Either you cannot understand what you're hearing and you cannot formulate what you're supposed to say. And T for telephone. Do not drive yourself. Do not ask anyone to drive. Do not call an Uber. Call 911. This is the fastest way. We're lucky in the US that we have a robust EMS system that if you call 911, they will get you. Mini stroke, I'm just going to go over it really quick. You're going to hear this. I had a mini stroke. I had a TIA. People use it for the same disease, which I disagree. So TIA is not equivalent to mini stroke. Mini stroke is, so when you say stroke, you lost brain function. TIA is not a loss of brain function. TIA is a transient ischemic attack, meaning you have a blood supply that was open or a blood vessel that's open. It got blocked. Your body took care of the blockage by our internal thrombolysis, and it opened up again. So you had a brief blockage, you have symptoms, opened up again, and then you have no consequences. TIA, by definition, if you do an MRI, it will be negative. You will not see any brain damage. So I don't like patients when they come and say, I had a mini stroke, I had a TIA. There's different. TIA is very important because if you have a TIA now, your risk of having a stroke in the coming month is very high. And this is an alarming sign that you need to see a primary physician. You have to take care of your diabetes, hypertension, all these chronic diseases that we really in a big need in the US, in my opinion, for a robust primary care system that takes care of those diseases to prevent the bad consequences that we see late when they come to the hospital. So let's concentrate on ischemic stroke. Hemorrhagic stroke is basically you have uncontrolled blood pressure. Either you're not taking your medicine or you're not really following with your primary physician that made you aware that you have a high blood pressure. Then the blood pressure keeps bouncing those tiny blood vessels. Then at some point they give up and they burst. So let's talk about ischemic stroke, which is there's a lot of evolution around treatment of ischemic stroke. Back in the days, ischemic, I would say 1996 and before, ischemic stroke used to be, you come to the hospital, okay, you had a stroke, we have nothing to do for you. We'll give you aspirin to prevent strokes from happening, but whatever happened, we cannot change it. That has changed. Risk factors, you name it. Those are all the risk factors that are really linked and associated with heart attacks. Again, the same concept. We have some added at the end that can specifically cause a stroke despite having normal blood pressure, diabetes. Sickle cell in African American here in the US is one of the diseases that is under looked at, to be honest. And people should really pay attention that sickle cell disease can cause a stroke. Drug abuse, also one of the big things that we see in our hospital. So act fast. Remember, if I finish this talk and you remember these two, ischemic stroke is a reversible curative disease if treated early, and treatment is time dependent. So what is unique about the brain? Why we're really focusing on come fast, let's get fast treated? Because the brain by itself, as we know from medical school, if you have a brain damage, the brain does not regenerate. Neurons or the basic cells of the brain, if you damage it, it does not come back. What the brain does, the brain tries to find bypasses, what we call it detours, for the area that's not functioning. So if you have a brain tissue like here, and this place is damaged, the brain will try to find detours to bypass this damaged area. Not like a bone. A bone, if you have a fractured bone, you bring them together, you wait a little bit, then you will have a new bone. The brain, if you have a damage, it will look like this. It will stay damaged. And that's why trying to treat it timely fashion is the key. Again, probably you learned me from now. I like to put things into perspective. So if you have a blockage in one of your blood vessels now, and you fast forward 1 second, there's 32,000 neurons in your brain that will die immediately without coming back. If you fast forward 1 minute, 1.9 million neurons will die in 1 minute without coming back. If you fast forward 1 hour, staying home, not calling a 911, nobody saw you with a stroke and picked you up and alerted you that you have a stroke, you will lose 120 million neurons and your brain will age by 3.6 years. Now, if you stayed at home, did not come for any reason, the stroke is completed, no treatment was given, you will lose 1.2 billion neurons and your brain will age by 36 years. So that is how important it is to move fast. From home, even when we come to the hospital, you will see the doctors will be moving like really crazy. The key again is pre-hospital. Families, beloved people, friends, pick up that you have a stroke. We should spread the word of be fast. Everyone who sees be fast should come to the emergency. And I can tell you, I had a lot of great stories where a grandkid picked up the stroke because someone gave them the talk at the elementary school. They called 911 and said, my grandpa had a stroke, and they saved their life. So there's a lot of good stories, but we have a lot of bad stories where people just sleep over it and they do not come to the hospital. Treatment of stroke is 3 arms. Medical treatment, which is just medicine. Those people, usually they come, either we pick them early after a TIA, or they come late and we just try to prevent strokes from happening. So we did not do anything for the number 1 stroke that they had. IV TPA, which is a tissue plasminogen activator, which it's a clot busting medicine. You give it fast enough in a specific time window, and it busts the clot if it's small enough, and it revascularizes the blood vessel. And the new treatment is the endovascular clot removal, which is physically going into the brain and removing the clot from the brain. If you go back a few years, 1996, I think it's one of the landmark years that changed the stroke treatment. 1996 is the FDA approved for the TPA, the clot busting medicine. At the beginning, the time window was 3 hours of the time the patient was seen normal, okay? So that's very important. It's the time when the patient was witnessed moving and talking normally, then you have to come within 3 hours of that time window. Then the window was extended to 4.5 hours. This is just quickly about the study between TPA and placebo, 3 months, 6 months, 12 months, favorable outcome. And you can see from the graph that TPA had a favorable outcome. Now, the major risk we're taking when we give you clot busting medicine is you will make the blood thin and you might bleed, okay? That's the major risk we're taking, bleeding anywhere, either in the brain or anywhere in the body. Even with that, the death in patients who got the TPA was lower than the patient they were left without treatment. So it's safe and it's effective. And it is now a standard of care for anyone who comes to the emergency within 4.5 hours of the last known they receive TPA if there is no contraindication. Let's start by a case, and let's walk through the case from 1996, then 2015, I will tell you why 2015, and then 2018, where evolution happens throughout these years. So let's take this, a old man, hypertension, hyperlipidemia, coronary artery disease, acute onset confusion, right-sided weakness, and the exam is consistent with left MCA syndrome, which is major blood vessel in the brain being blocked completely, and the picture is consistent with that blockage. Usually what we need when we see patients really quickly from EMS or from the family is handedness, because we know that in right-handed people, the left brain is the dominant brain, so we know which dominancy is in each patient, last known to decide on treatment option, and so forth. We collect information. Then we rush the patient to the CAT scan to get an image of the brain. And this should happen fast. So the number 1 disease that you will not wait in the emergency in a waiting 4-6 hours, I can tell you that when I got my kidney stone, I was kept in the waiting area for 6 hours with renal pain because it's not a stroke. But stroke, they will not let you wait. You will be rushed. So we rush the patient. Usually, we start asking questions. When was the patient last seen well? Who knows the patient past history? Let's collect any contraindication for TPA, and we go really quick. What's next? We collect ABCs, vitals, blood pressure, we collect some EKG, some labs. And we do something we call NIH stroke scale, which is a standardized exam that if I do it and someone do it in a different state, different country, we can come into a conclusion how bad is the stroke. Anything above 6 is pretty bad stroke. Anything below 6 is a mild stroke. And then if you go higher, above 6, the higher the number, the worse is the stroke. It has multiple components. We're not going to go through this, but this patient has a score of 26, which is a very bad stroke, and it reflects if this patient left untreated, the chances for them to die within the coming month is about 70%, and the chance of being disabled is probably 100% if they do not get any treatment. So what next? To give TPA, you need 3 things. You need to rule out any contraindication, any major bleeding, any recent trauma, any major surgery in the last few months or few weeks. There's a list of contraindication, and you need to do 2 tests. You need to do a CAT scan of the brain to rule out bleeding, because if it's a bleeding, we do not give clot-busting medicine. We should not give it, right? So this is one thing that if you do it and you see a bleeding, you do not do a TPA. And the second one is a blood sugar or glucose, because high glucose and low glucose can mess up the brain function and can look like a stroke. That's why those are the 2 tests we need. Otherwise, you do not need any test. So CT scan of the head, non-contrast, and blood glucose. In this patient, the glucose was 110, which is within normal limit, and the CT scan showed no bleeding. This is the CT scan that we did on this patient. What are the therapeutic options? Let's say we're in 2000, year of 2000. It's TPA. So we go over the contraindication. We're not going to go over them. The slides will be ready for anyone who wants them to look at this. But we go over the contraindication very quick, because remember, time is brain, and we have to act fast. And we give TPA. So this patient was given TPA. Unfortunately, the patient did not improve. As we learn from using TPA has some limits. The number 1 limit is 4.5 hours. Only 20% of the patients with acute ischemic stroke, they come within the window of 4.5 hours. The 80%, they come late. So this is number 1 limitation. Number 2 limitation is there's a risk of bleeding. Number 3, we learn with time is the bigger the clot, the bigger the blockage, the TPA as a clot-busting medicine does not work in a perfect way. So it is limited. We're giving it IV. It has to go through the system, getting activated, then go to the clot, and then try to bust it. So the bigger the clot, and even there's a study that looked at in Memphis that looked at the size of the clot. Any clot above 8 to 5 millimeters, it's unlikely that the TPA will bust it. So that made scientists look into these limitations. And also, the larger the clot, the more chance of death. Like look at this table at the bottom. ICA stands for internal carotid artery occlusion. MCA is the major blood vessel behind the eye, which is this one, supplying the whole side of the brain. And basilar is the back of the brain that supplies the brainstem. Blockage in each of those, this is the mortality rate. Look at the basilar. The mortality rate is up to 90%. If you come to the emergency with a basilar artery occlusion, the chances that you will leave this hospital alive is only 10%. So identified those limits. What else they looked? They looked at, can we access the clot? So if the clot is big, can we go to the brain and pull it? And our colleagues in cardiology, they were ahead of us. They go to the heart all the time, and they put stents, they remove clots, and they did it. But the cardiologists, they're smart, but their life is easier. Why? Because for them to take someone to a cath lab to remove the clot physically, they need 2 things. EKG showing that the patient has a STEMI, we call it STEMI, ST elevation MI, and a chest pain with some enzymes. So this is very quick to do, and you do not need to do any further imaging or to locate where the clot is. Is the clot in this location or in this location? Is it safer here? No, they just take them. In our case, we should look into a stroke that is easy to identify by images. Bad outcome if we do not remove the clot, and the clot can physically be removed. And those clots that we identify that we can remove is anything from here up to here. So anything below we can remove, but not the blood vessels that very tiny like this. We call them lenticular striate. We do not remove those clots. But anyone in those major pipes, you can remove the clot. This is very accessible. And also they looked at if we open those blood vessels, does the outcome and the death decrease? Yes. So if you open those by TPA by chance, which is the 10%, people do better if you remove the clots. So we identify those patients. And do we have the tools to do it? Yes. We have the biplane angio suite, and we have access either from the femoral artery or from the radial artery. And then the last piece before you start any study, can we measure the outcome of this treatment? Yes. We have something we call modified Rankin score. It is a functional outcome that we measure outcome after stroke treatment. And it's from 0 to 6. 0 is us, walking, talking, no problem. And 6 is death. And this is from 1 to 5. 1 is someone who had a stroke, got the treatment, and went back to normal life, driving and working. Number 2, with some mild weakness, maybe a facial droop, some numbness in the hand, but they can still work. 3, 4, 5. And they identify that if we're going to do any procedures on those patients, the good outcome should be 2 and below. We're not going to even look at anyone with a cane. Cane is for them was not a good outcome. Although, in my opinion, a cane that can allow you to reach your car and drive, go to HEB and get groceries, why not? It's enjoy a cup of coffee, why not? But they when they do trials, they look really at a very strict criteria to make it looks the best outcome. So we have a route to go in. We picked up the clots that makes people die if we do not do anything. So there's nothing to lose, quote unquote, and then a good outcome. And they did these studies. In 2013, I was still a medical student. I was very passionate about this field, and my passion went down after these trials. We had 3 trials back to back in New England Journal of Medicine. All of them, they were stopped, or 2 of them, they were stopped prematurely because of the first one showed that pulling the clot from the brain was disaster. Patients were dying. There's no good outcome, a lot of bleeding. You go in and try to remove the clot, then you end up with a massive bleeding and the patient die next day. So they stopped the trials and they said, this is not a good design, and stop doing it. But physicians, people in the medical field, they're very stubborn. They learn from their mistakes. What they learned that imaging were not used at all time to detect large vessel occlusion, LVO. They were just taking anyone with a stroke to the cath lab, which is probably was a bad idea. You should really triage those and know which one I should take and which one I should not take. Number 1, so not all patients in those trials got imaging to pick up the clot. Number 2, they did not exclude patients that they showed already stroked out brain, because we know that the brain, when the brain dies, it does not come back. So why they were taking everyone regardless? That's also mistake number 2. And they were not really looking at the timing. They were taking anyone, 6 hours, 8 hours, 12 hours, 24 hours. So they learned from those mistakes. And the last mistake they did is they did not use new tools. What literally they did, they used something we called Mercy device, which is this one on this picture. It is basically a loop-to-loop string that is FDA approved to remove foreign body from the body. For example, if someone is using a wire to reach the renal artery and the wire breaks and it's flowing into the brain, into the body. This device, you go in, you screw it, the wire will get tangled and they pull the wire. So because they were very excited, they went to FDA, they said, listen, this Mercy device, we pull foreign body objects from the body. The clot is a foreign body. So probably it will work. And FDA gave them clearance to use it. And that was, in my opinion, a mistake, because they use a device that's not designed to remove a clot. It's designed to remove a wire, but not a clot. And that's probably one of the problems that they faced. So, and this is how they use it. It's basically this device. You go in, you start screwing it, and you hope for the best. Okay, so it was not a good idea to begin with. So they learned from those mistakes. They engineered devices. This is one of the famous devices that we use. It's a stent on a stick. Basically, you deploy the stent within the clot, wait 2 minutes, the clot will integrate within the stent, and then you pull the stent with it. I will show you a video just to give you a perspective how it works. And they start to really going creative, okay? So there's an aspiration catheter, which is basically a small vacuum. This one of the famous ones. You just put it to the face of the clot, put it on a vacuum, and it will suck the clot out, and so forth. So they designed that, and also they worked on the design. So we have to take specific patient population, patient whom we prove they have a clot, number one. They come within 6 hours window, and we take them only, those patients will take them to the NG suite, not anyone. And we have 5 randomized trial back-to-back in 2015. The only trial that completed until the end is the first one. The rest of the 4, they were stopped prematurely. Why? Because the first one proved efficacy. They said the first one showed really 80% good outcome. Stop, go ahead, FDA approved. It is approved. And that was really the major year in stroke care, I believe, in the whole world. And those are the trials in details for people who wants to look at them. And it was part of the guidelines, and it was approved. Now, how effective is this treatment? That's a question that I always been asked. Is it like, is it just only fancy? You take patients and you pull the clot and hey, we did it? No. We published papers with my colleagues in the East Coast a few years ago is looking at the number need to treat. So just in summary for people who does not know the number need to treat in medicine, it is the number of patients that you need to treat in a specific treatment option to prove the outcome. So for example, if I have two medicine in my pockets, right pocket and left pocket, and I tell you that this medicine in this right pocket is very effective, and to prove to you that it's very effective, I will only give it to one of you with a specific disease, let's say a pneumonia. I will give you to one of you, and that person from the first trial, they will improve. But this one in my left pocket, it's a little bit challenging. So I have to treat half of you guys to show you that it works. So which one is more effective? The lower the number, the more effective the treatment. So look at those common diseases in medicine. Bariatric surgery for morbid obesity to prevent heart disease and death. The number need to treat, the number of patients you need to do bariatric surgery on is up to 70 patients to prove outcome in one patient. Aspirin for MI, aspirin for cardiac heart attack. You need to give 50 patients aspirin each time to show that aspirin in that patient worked and they prevent death and heart failure. PCI, which is cardiac catheterization for MI. Sepsis with early goal-directed antibiotic. Lice treatment, you have to treat up to 7 people to eradicate lice. Defib for VFib, which is ventricular fibrillation. Look at the mechanical thrombectomy for stroke. You need 1.5 person to treat to prove outcome. So by far, and I would love if anyone correct me or not, it is the most effective treatment in the history of medicine so far. Since medicine was invented, this is the most effective interventional treatment for a disease that prove outcome with a very low number need to treat of 1.5. And yet we only have 20% of the patient population who come to the hospital within the time window to do this procedure, which is very sad. So back to the case, the old guy with the left MCA. So let's say the patient came in 2015 after those trials. Now we know the drill, right? So we do a CTA. This is a CT angiogram showing the blockage in the MCA. So this is the right MCA, and this is the left MCA. It's blocked. So we prove the blockage. He came within the window, and this is one of the techniques that we use to remove the clot. So this is just a schematic video. So we first go with a wire, a very small wire, 0.014 wire, and then we follow it with a small catheter. Within the catheter, we deploy the stent. We open the stent, wait 3 minutes, and then we pull the clot with the stent. So this is one of the techniques that we use inside the brain, and that procedure usually takes probably 30 minutes. And this is before and after. And this is how the clot looked like. This is the stent with some pieces of the clot. This is the balloon that we use, and this is the clot itself. We do not leave anything in the brain. We just pull everything out. This patient that we talked about left the hospital within 48 hours. If this patient, in this case, did not get the treatment, the chances that he will be dead, this is by statistic, not by Mohammad speaking that, will be dead within the coming month is around 80%. And he would never be able to talk and walk after that if he did not get the treatment. So he went back to his grandkids, and until now he still texts me. I gave the wife the number, and she said, thank you and with the grandkids, thank you for keeping him alive to enjoy his grandkids. Now, again, physicians are stubborn, and now they looked at, is it only 6 hours? So what we discussed before, the 5 trials, they approved the treatment within 6 hours of the time of patient was normal, and then 6 hours until they reached the hospital. Now they said, okay, what about after that? What about if the patient woke up with a stroke and we didn't know, did the stroke happen while sleeping, at the beginning of the sleep, last hour, last 2 hours? And they start to think outside the box. And the reason why they start thinking about is the way the brain behaves when you have a blockage in the blood vessel. So if this is a brain, blood vessels, and you have a clot traveling into the MCA like this. People would imagine that if you have a blocked blood vessel here, all of this area will die immediately. But that's with studies and science, imaging, and also basic science, we learned that this is not the case. What happened is the brain, not the whole area will die, because we do have something we call collaterals. So the blood vessels in the brain, they talk, they try to help each other. And that's why what happened is when you block this, you will have a stroke at the middle of the blockage, but the whole area around it, we call it penumbra. This is a struggling brain tissue that's asking for help. So the penumbra, in different words, is a brain tissue that is telling us, please get the blood back. I will start functioning if you get it to me in 24 hours. And the core is the tissue that even if I reperfuse, that tissue is already dead. And with time, people wait, they do not get the treatment, the core will increase and the penumbra will get slower. Then at the end, you will have a complete core, which is a tissue that it is already dead. If you open a blood vessel, nothing will happen. How do we see this on images? Like we're not gonna slice each brain in the ED to see which one is the core. We have a CT perfusion, which is basically a CT scan with contrast that looks at this. How much of the contrast is staying in one location, not being actively removed, and how much of the contrast is really flowing but slow, struggling. And this is what we see. So the upper part is the core infarct in this patient, and this colored is the tissue that's struggling and asking for help. If we identify those patients, and this very quickly done in the ED, within 10 minutes you can do this, all the images within 10 minutes. And you identify those with a big penumbra, small core. Still, if you remove the clot, you can help the patients. And we nowadays, after those 2 trials, Diffuse and Dawn trials in 2018, now we treat patients up to 24 hours. So it's no longer 6 hours alone, it's up to 24 hours. And this is just a study showing how much shift in good outcome we saw. This is just the statistics, and it made it to the guidelines. Now it's now a guidelines by the American Stroke Association. And this is how the clot looks like as well. Now, I have one slide to... We did raise this question again. Same colleagues I worked with. This is a paper we published after the Dawn and Diffuse. Did the number need to treat change? Like, was it 1.5 and now it's 50, 60? Should we just really not advocate for this? It's not really helping. No, it did not change. So if you look at this, mechanical thrombectomy by Dawn and Diffuse, which is 24 hours, the number need to treat is 2.6 patients. So it is still effective, and it is still needed. And again, unfortunately, less and less patients are coming, because still, I think we should do a lot of work, starting from here, from medical school, teaching our beloved medical students that go spread the word, go to elementary school. I went to my kids' elementary school in Arizona. I taught them be fast. I took a frog brain and I showed them the brain and stuff. So it was very interesting. And starting with the community, medical staff or people in the medical field, even going to church, teach the young, because the young will see the old having stroke. I think this is something we should work on, that stroke is a treatable disease. Come fast, be fast, and you will get your function back if you come early. And I will stop by here for any questions. Any questions in the chat, or that's good? Probably.
Any current application for using what people call regional at a place or TPA, right? That you go back and intervene the vessel and just applying, not really locally, but regionally to the vessel.
So part of the first trials before the 2013, that's a great question. Thanks for asking. So the things that they tried at the beginning was to give TPA locally. So we go with a microcatheter and we give it there. To be honest, the studies did not show really as effective as the stent mechanical thrombectomy. We call it chemical thrombectomy. It was not that effective. And remember, like TPA, the way it works on a fresh clot. So if the clot has been sitting there for a long time, a lot of thrombin and more organized, the TPA usually does not work. I do it when I fail the mechanical thrombectomy. Usually you go, or maybe sometimes if the clot is very far away and my wires was not able to reach, I go as close as I can. I give 2 milligrams, 1 milligram. Is it effective? I think it's the last resort. But the studies, I did not mention them here, were not as robust effectively as the mechanically removing the clot.
And the second question and last is related to the penumbra and calcium channel blockers, right? So then in the studies using stents removal, there is a need for treating the penumbra area, or showing the improvement is independent of the penumbra?
You mean the improvement in people with a core and a penumbra?
Improving in patient outcome and rehab, no sequelae, so not having any consequences, right, are related also to treatment to the penumbra area, or just by using either coiling or using a stent is sufficient to prevent those consequences?
No, you're right. The bigger the penumbra, the more better outcome you see. But I would not exclude patients with a small or borderline penumbra. The reason why I did not mention it here, there's trials that came in Europe last year that even looked at people with complete core. Like in Germany, they did 2 trials. People who had complete core, you do a perfusion, there's no penumbra, and they did thrombectomy. Those patients improved as well. Improved in a different way. Improved with less brain edema, less herniation of the brain, and more time for bypasses to be formed. So I think the future is coming. Hopefully in the US, if the FDA gets it approved, we'll be doing thrombectomy even with a big core to prevent those consequences. But definitely, the bigger the penumbra, which is the faster the patient comes, the better the outcome if you remove the clot. That's completely correct. Thank you very much. Yes.
What is the approximate success rate of getting the clot out?
So if you go by the trials, any clots in the identified place of LVO, large vesicle occlusion, which is MCA, ICA, and M1, M2 branches, which is a specific location, the success rate is up to 85%. We can pull it. Now, I've seen in my practice, I do not really have any way to prove it with studies, is the longer they wait, the less you're gonna, because it's more organized, more attached to the wall. So you're gonna be pulling, but I would say 85%. Anytime. Nothing on the, all right. Thank you very much. Yeah, you have one?
One question from Danny. Do the stroke centers all have the most modern equipment, the stent removal clot?
That's a great question. So Now, we're trying to organize centers across the country. Definitely, if you have a center that you know of called Comprehensive Stroke Center, and that is a designation that's very strict. Comprehensive means that they can do everything for stroke patients. There's another designation called Primary Stroke Center. Those usually they give TPA, just the clot busting medicine, then they transfer you out. To do the clot removal, you have to have a comprehensive team of starting from nurses in the ICU, neurointerventionalists like me to pull the clot, and then neurosurgeon to take care of any consequences from pulling the clot. So comprehensive, having all these stakeholders together is in specific programs. I would say Comprehensive Stroke Center program designation is where you will have this. But could it be done somewhere else? Yes. There's a thrombectomy ready places where they just do thrombectomy and then ship you out. But to simplify the question is only highly equipped centers. We call them comprehensive stroke centers.
Do we have any additional questions today?
Thank you very much. Thanks for having me. Thanks.
Dr. Saeed, do you have a question?
Yes. I'm an ED physician. This was a highly relevant lecture. Thank you for the information. I wanted to go over CT perfusion versus CTA. I mean, is one better than the other? Should we prioritize getting a CT perfusion or the CTA in the emergency department for acute stroke?
Thank you very much for this question. I think it's a great question. In my opinion, and based on the studies that I showed, which is the 5 trials in 2015 and the Dawn and Diffuse for extended window for the penumbra in 2018, I do believe that CT perfusion has a great value only if it's done 6 hours and above from last known well. Before 6 hours, according to the 5 trials that I showed in 2015, you do not need any further imaging. Patient comes in, last known well, within 0 to 6 hours. What you need to help people go to the cath lab or NG suite is a CT angiogram to prove where the clot is and where the blockage is. You do not need CT perfusion. I do believe CT perfusion before 6 hours increases the confusion because perfusion for the radiologist on the call or expert in the radiology, it can confuse this before 6 hours. It can show you a core, although it's not a core. It can show you no penumbra, although it's falsely negative, falsely positive. So bottom line, I think 0 to 6, you need a CT scan of the head to rule out bleed and a CT angiogram to prove the blockage. 6 hours up to 24 hours, I would add perfusion to help picking up the penumbra. Now, is the field gonna be like this few months from now? I do not think so. I think if I have a crystal ball to predict, I think in a year, we're gonna be only doing CT and a CT angiogram. And even sometimes we're gonna do just CT and that's it. After the German trials showing that even if you pull the clot from a complete core, the outcome is improving. I might be optimistic, but I think in the future, we might get rid of the CT perfusion, I do believe. It's gonna be more of prognosticate patients, having more dialogue with the family about what to expect. But I hope I answered your question. So to summarize, 0 to 6, CT, CTA, 6 to 24 hours, I would add a CT perfusion.
We do have another question from Danny again. If you see a person out in the field and suspect a stroke, is giving an aspirin appropriate given that most strokes are ischemic?
Danny, great question. That is a common practice in cardiac. So if someone comes in by EMS with a chest pain and a STEMI, they crush aspirin. In stroke, it's very difficult to do that because you do not have the gold or the #1 gold standard images, which is CT scan to rule out hemorrhage. What if you give an aspirin to someone that you assumed it's ischemic stroke and it turned out to be hemorrhagic stroke? You might cause harm. Now, to come around this, now in Houston, Houston is famous about the mobile stroke unit, which was invented by Dr. Grada. He's our godfather of stroke in Memorial Hermann. He invented with his colleagues the mobile stroke unit, which is an ambulance that has a CT scan inside. So the ambulance will come to your home, detect stroke symptoms, they put you to the CT scan in the ambulance and they do a CT scan. If you do that, I think there's no harm of doing aspirin, but at that time you probably give TPA. But to answer your question, I would not advocate for aspirin for all strokes, assuming that it's 85% all the time. Thanks, Danny, for the question.
And this is from Dr. King. In terms of imaging, do you see a future for MRI, MRA stroke protocols in primary or comprehensive stroke centers?
I do believe MRI adds a lot of value. It does add value on more on the core and penumbra, even more comprehensive than a CT perfusion. The problem, as we all know in practice, is MRI is very difficult to do in a very fast manner, right? So MRI is a big magnet, so you cannot push patients for MRI. Everyone who comes from the door, because you have to do a screening, you have to rule out any devices, defibrillators, any metals in the body, any gunshot, so it's very difficult. I had the honor to work in University of Arizona in Tucson, where our protocol was CT scan, MRA, MRP, MR perfusion. And we had a dedicated MRI for stroke patients. We had a specific way to rule out metals in the body and certain things. But did we face some challenges? Yes. I mean, for simplicity and for most of the centers in the US, it is not easy and feasible to do MRI. Would I love to have MRI in all centers? Yes, but it is not easy to have. But it does add a lot of value. Yes, correct. Just not practical.
Do we have any additional questions?
I mean, it sounds like if we wait more, there's more questions, so let's quit. Yeah. All right, thank you very much again. Thanks. Should I stop sharing and stop recording? I don't know. Okay, thanks.